Hello, and welcome to the Drs Clinical Education Neuroscience Podcast. I'm your host, Tarini. Today's episode features Srikanth Muppidi, clinical professor in the Department of Neurology and Neurological Sciences at Stanford University. Pushpa Narayanaswami, professor of clinical neurology at Harvard Medical School and vice chair of clinical operations in the Department of Neurology at Beth Israel Deaconess Medical Center. Henry Kaminski, Jeffrey Lieberman, professor of neurosciences and professor of neurology, pharmacology, and physiology at George Washington University, and principal investigator at the MG-NET Rare Disease Clinical Research Consortium. Pratikanta Paul, assistant professor of neurology and co-director of the EMG clinic at University of California, San Francisco. This episode is part of a larger educational program titled From Mechanism to Management, Novel C5 Inhibitors in Generalized Myasthenia Gravis. For more information on our faculty, along with a link to the larger educational program, please visit the show notes for this episode. Now let's get started and hear what the experts have to say about this important topic.
I'm Sri Muppidi. I'm a neurologist and faculty at Stanford University, and I run the myasthenia clinic with one of my colleagues. And we deal with myasthenia gravis of all subtypes, ocular, generalized, with different levels of severity. And there is, in spite of sort of dramatic improvements in therapies over the years, especially in the last 6-7 years, there are still challenges in terms of caring for patients with generalized myasthenia gravis. There isn't one single unmet need. I think it depends upon the patient and what their challenges might be. For example, there are patients with significant symptom control issues, are not able to tolerate certain medications, let's say prednisone, for example, because of side effects. And we would like to try to escalate them to newer therapy where there are challenges with getting insurance approval in a time frame that is considered reasonable or acceptable for a patient. And so those are some of the challenges that we currently deal with. The quality of life is an ongoing challenge. It's a little bit more difficult to define. It's very patient specific. And there isn't one quality of life that will be considered acceptable to every patient. And we try to sort of adjust the current therapy, both in terms of benefit from the therapy, potential side effects, and even the financial burden of the therapies. And what is it that the patient is trying to do? What is their job? What is their current activity level? One of the things that the rest of the faculty also have shared this sort of practice. If you were to see a surgeon and they have double vision, any degree of double vision would not be acceptable. And this has happened in my practice. The surgeon had to retire because no matter what we did, the double vision could not be corrected. Now, if otherwise a retired professional with mild degree of double vision, one might not need to escalate a lot of therapy because they might be able to function well. And so there isn't one single fit approach. We try to approach the patient based on what they do, what is their main symptom burden, and what kind of treatments they can tolerate.
I'm Pushpa Narayanaswami. I'm a neuromuscular neurologist, just like the others here, with an interest in myasthenia gravis. I'm professor of neurology at the Harvard Medical School and vice chair of clinical operations at the Beth Israel Deaconess Medical Center for the Department of Neurology. First of all, I'm going to sort of take objection to the term unmet need. A need is unmet, so I've never actually understood why we say unmet. If a need is met, it's no longer a need. So we'll go from there and we'll talk about needs, I think. And Shree's grinning because he knows this. I get on my pulpit about this. But I'm going to actually take a step back and say, look, a vast majority of our patients do well. And that, I think, is something that we have to remember. And I think that percentage, if you actually look at, papers looking at clinical practice, in addition to one of my own studies, is approximately anywhere from 60 to 70%. But then it depends on what you mean by do well and how you define do well and whether the definition of do well should be changed, but, because of the therapies we have. And I'm not so sure yet. So if my patient is able to come off of prednisone to 5 milligrams a day or less, or even off of it, or they're on 500 milligrams of mycophenolate, and they're fully controlled with their symptoms, and they tell me that they're back to work and doing what they need to, and a woman can go ahead and have her baby if she wishes to, I think that's reasonably good, more than reasonably good. If they tell me that for whatever reason they're not doing well at that time, then I'm going to actually explore that and see why they're not doing well and how much of it really has to do with either the disease or the drugs. So the point, as we talk about, is that the goal of taking care of these patients is really to get them to a functional point defined both by them and by us, and at the same time to have minimal or no side effects. But I agree that for the other 30, 35, maybe 40%, probably around 30, 35% of patients, there are really challenges. And that's where I think we have to think about it. And as Shri really put it, it isn't one particular challenge. The first thing, obviously, as physicians, we are looking at is, okay, is your disease controlled or not? And what have we done with control? And, yes, there are people with whom we can't get their symptoms controlled, or we get them controlled at the expense of really bad side effects. So that's the first level. That's the highest level. We haven't even gone beyond that. And then there's this phenomenon called goal resetting that was initially described in oncology, but we see it in most chronic neurological diseases as well. When patients are really sick, that they're willing to do anything, and then they want that some improvement of symptoms, and they feel better. Once they feel better, they start thinking about convenience of therapies. They start thinking more about side effects of therapies. They start thinking more about my lifestyle. I don't want to go in there every 2 weeks for an injection. So that goal resets. So I think the definition of need changes with time. And I think that can encompass all of these things, quality of life, everything that Shri said. But I think that's something to also bear in mind when we take care of patients.
I'm Srikanth. I'm one of the neuromuscular faculty at University of California, San Francisco, and also co-direct MG clinic with one of my colleagues here. So talking about MG, I have my clinical research interest in immune-mediated diseases, including MG. And talking about the needs in MG, I'm compared to other faculty here, I'm relatively junior in that sense. I get to have more medications available in the last few years, very exciting times for MG, but I see it as a little bit of confusion in some sense, because we are in this era, we are switching treatments, or need to switch treatments from one medication to another. So that's quite a huge challenge at some level. And I wanted to take a different angle to this question at the unmet needs. I thought about it, how our clinical trial data includes only some sort of subpopulation of MG patients who are relatively stable. Based on my experience, I feel like the patients who gets enrolled, many of them have the studies have this criteria, stable MG disease, or like MGFA class, not more than 4. So, that's kind of where you almost have a relatively smooth journey compared to many of our real world patients. It's significantly impacted by other comorbidities and what drugs can have side effects. And so that kind of makes a real type of challenge, number one. And the other thing, talking about from the patient's perspective, as others mentioned, one of the big goals in the real life is how quick and how low can you go down on the prednisone? Because we know prednisone is one of the most efficacious drug that kind of works in most occasions, particularly at a higher dose. We talk about in the trial data, like there has been reduction in the percentage, but in real life, it makes a huge difference if someone goes down on the prednisone from 30 to 20 versus if you're able to successfully lower the prednisone from 20 to say 7.5, and that often can be very challenging. We mentioned about one of the eye symptoms, which often tend to be very prednisone dependent. I have seen patients like, you go down, they're on other adjunct therapies, but you go down on the prednisone less than 10 and the eye symptoms come back. So I feel like, there has been like a huge need in trying to identify and kind of close this gap or mismatch between the clinical trials we do and the real world data. There are either certain patients who do very well without much, only maybe low dose steroid, but then there are kind of quite a large population, not like definitely more than 30%, but then still like it can be very debilitating for the patients in terms of the symptom control. And again, a huge thing, I think one of the recent studies showed even between newer drugs, between complement inhibitors and FcRn, there was quite a kind of up to higher percentage of not adequate symptom control over the long run. So I think we are in that current situation where the need is more for how do you define like the goals of care. And as everyone so far highlighted, it can often change with time and like the other medical situation. So that's super important. It's exciting to we have more options, but I think it's also quite gap of knowledge. Okay, so which drugs to start with as the first line therapy when patient with MG, generalized MG comes in? Which drug to start with, and how do you make that decision of switching to treatment? How long should you wait for the effects to be noticeable? So it's a lot of information which are still missing in the real world data, I would say.
So Henry Kaminski, I'm a neurologist at George Washington University in Washington, D.C. And for the last 30 years, I've been doing clinical and translational research in myasthenia. And, I think I'm just going to echo what my colleagues have said, but try to put it a little differently. As I see it, there's really very two challenging groups. There's the patient who's presenting to you with symptoms early on in the disease, and you don't know whether that individual is going to be one who is going to be treatment resistant into the future or treatment sensitive, so and agnostic initially to the treatment. So that's a need for the physician as well as for the patient, because as you heard, 30% probably is a good number that are resistant to treatment, but that means 70% of people are really going to do well with what I'll call traditional prednisone, immunosuppression, get to relatively limited adverse effect profile with those agents. Immunosuppression and prednisone are targeting antibody-producing cells, which is not the case with FcRn and complement inhibitors. So that's a challenge there. And then what others have talked about is those people that are treatment resistant. And in both those groups, as Sri mentioned, insurance approvals really compromise the way we can use these medications. So, for example, I could imagine a scenario where I'd really like to use an FcRn or a complement inhibitor in a new onset patient. They're an outpatient that on the verge of becoming an inpatient, and I can't get these rapidly acting treatments approved quickly enough. And so in my experience, going to IVIG has been an opportunity, but then there's problems with that, right? And then, what I do think is a real benefit for our patients is these treatment-resistant patients, they fulfill the criteria of the clinical trials. It takes a little time to get them approved, but with a little bit of effort, we're able to utilize those more recently developed treatments. Having said that, as has been pointed out, even if you just look at the clinical trials, there are patients who are responding, but not responding wonderfully. And I've seen that in my clinical experience. There are really amazing responses to some of these agents and some that just aren't. And so again, being able to predict those people who are going to do better or worse is a need. Just to comment further, there are those, as Pushpa indicated, the need to tailor expectations to the patient. And I'm not going to repeat what she said, but I would say there's also the individual who comes to see me, they say they're doing well, then on examination, they're clearly weak, and they've adapted to the disease. Because we all try to adapt to the disease or any disease, because we want to live our lives as normally as possible. I think we need to be on the lookout for better ways of monitoring our patients as well to detect these patients who are just putting up with a good amount of weakness. So I'll leave it at that.
I had a close relative with myasthenia gravis, and I remember when she was going through the diagnostic process, and it seemed to take so long, and it was so frustrating, and there was so much discouragement, not only for her, but for the family. And it just seemed like she's having all of these symptoms. she's not functioning well, she's exhausted all the time, mentally, physically, emotionally, just trying to get through her day and figure out what is going on with her. And nobody seemed to know. And it kind of became, you know, an unspoken joke. Um, what's the diagnosis of the week? And it was partially out of frustration, partially out of just trying to get through whatever was going on. And when she was even at one point had to go through a psychoanalysis, like, oh, is this all in her head? It clearly was not in her head. Her physical symptoms were very real. And when she was finally able to get in to see a specialist, there's a waiting list. Then you have to wait to get in to see the specialist when she finally got referred. And then, she lives in a rural area, so she ends up having to travel to go see a specialist. So it seems like that diagnostic time from symptoms to getting treatment or getting in to even get the correct diagnosis hasn't gotten any better.
I think there are access issues and can be a number of different things. When it comes to complement therapy, one of the access issue is sort of discussion regarding potential side effects that are unique to complement therapy and the vaccination requirement and potentially antibiotic prophylaxis requirement. And so that is a specific, very unique intervention that we need to do for this particular line of therapies. The second one is insurance approval. This has been an ongoing challenge, and I hope it gets resolved, but there isn't a single simple solution. There's a lot of variability in how different insurances will approve a complement therapy for a patient. All of them certainly require AChR antibody positive status, reasonable, it's approved for that condition. But some of them require a certain degree of MG-ADL score and MGFA status. Some don't always require that. So there's sort of variability that we have to manage and work through. And then obviously the cost of care, which essentially translates to the degree of hurdles and burden that the clinical team has to pass through to get the drug available for a patient. So there is always a lag time when I see a patient in clinic and say, we would like to start a complement therapy, to the date they actually start a complement therapy. And that is an ongoing challenge. And I don't have a quick solution, but patients do struggle because of that lag time.
Oh, so I just wanted to step back. There's the access once the patient comes into your room and you're prescribing the complement inhibitor or whatever treatment, just like Sri discussed, but there's also the access to a specialist. And I think that's, for the community of myasthenia gravis patients, that's a significant problem because we get many patients who've been treated inadequately for years. And I think there's more and more information that supports early diagnosis, recognition, and treatment will benefit the patient and perhaps even on the biological level and not just the psychosocial level. So that's the only thing I wanted to add, that the huge need for being able to recognize patients earlier and not with a 1 or 2 year diagnostic journey.
I just wanted to quote from a recent example. I was trying to put one patient on complement inhibitor, and then their PCP encouraged against vaccine. I don't know if you see it as an access issue, but that's also talks about, the access to the expert, et cetera, and awareness, so that's a huge thing, particularly for complement inhibitors. I have to, again, go through that and explain things, weigh risk versus benefit, where other physicians may not feel comfortable supporting that idea, and then patient is in between, right, somewhere. So I think that kind of was also an interesting, what just happened to me recently, particularly for complement inhibitors.
2024 study out of Denmark, fairly large. Again, the average time to diagnosis is a year, and that's average, right? I do think with the modern electronic record and being able to apply various approaches to be able to identify patients early on when they have a series of symptoms. They're seeing an ophthalmologist for double vision, they're seeing an ENT for trouble swallowing, and put an alert in up to consider myasthenia gravis as a diagnosis. So, hoping for things like that going into the future, but right now, no.
I think in the United States, it's still very patchy. It depends on the areas we are in, suburb, an urban area with tertiary medical centers. Even there, the delay is present because we are fairly busy and booking out, but the access is there. And as systems grow larger and larger with hospitals buying up more and more smaller places, I think it's better. But the more you go into the rural areas and also by state, the coasts are better staffed. I think it's very, very patchy and sort of not quite the same everywhere. And that actually bothers me a lot because it's an equity issue. And Henry, if I may, so
Yes.
you took the words right out of my mouth when you talked about your last point. So, this is why I ask you, and because you have to be drawn out to speak. So just say.
I'm speechless now.
So regarding differentiating C5 inhibitors, so currently there are 3 C5 inhibitors that are FDA approved for patients with AChR positive myasthenia gravis. Eculizumab is given intravenously every 2 weeks after weekly loading dose of 5 weeks. Ravulizumab is given intravenously every 8 weeks. And the third one, zilucoplan, which is a peptide, which is given subcutaneously daily. All of them are effective in a sense that when you take a patient who hasn't been exposed to a complement inhibitor, both in clinical trial and clinical practice, there seems to be a clear improvement in symptom burden and overall control of myasthenia gravis. And when you look at the clinical trial data across the board, they all seem to have similar degree of reduction in their MG-ADL, for example. In clinical practice, there is some variability. With the ravulizumab being approved in our clinical practice, we predominantly use ravulizumab or zilucoplan as 2 options. We rarely use mab anymore. Many patients do quite well on either of those combinations. The way we choose which one to offer, which one a patient would like to try, really does depend upon patient preference. There are some patients who don't mind an infusion every 2 months and don't really want to be injecting themselves every day. There are other patients who really do not want to come to an infusion center at that frequency. They're remote, and they're more than happy to do this by themselves on a daily basis. From a safety and infection risk mitigation process, there is REMS protocol for all of the complement inhibitors, and the process is fairly similar with some variability with agents. We certainly, as neurologists, in spite of these drugs being available for so many years, this is still an ongoing process in terms of making sure the patients are adequately vaccinated and they're on a prophylactic agent if needed for a period of time, because now it's considered 6 months for the completion of the vaccination, and then discussing the ideas behind the vaccination and the need for maybe prophylactic antibiotic agent with the patient. These are some things that we have integrated into our practice to improve efficiency and reduce the time it takes. These agents, I think we talked about it earlier, are expensive, and there is a lag time between prescribing it and the drug being approved for patients in clinical practice. But in the bigger picture, I think these agents, C5 inhibition in general, has made a huge impact. I just wish that the process of getting these agents to patients and the start-up times were shorter than they are currently.
Thanks, Shri. As usual, going after you is really hard because you cover everything. Then I actually, as is unusual for me, have nothing to say, but I'll still say something. Yeah, I mean, I tend to agree with you, Shri. So the 3 drugs, it's really quite hard from the efficacy standpoint or the effectiveness standpoint in clinical practice to sort of differentiate them. What I will say is sort of going back to our previous question about needs and emphasizing what Henry said, not all patients respond to these drugs, even though they are these magic bullets, right? Again, if you look at the trials, the sort of that magic number appears to be around 60%, 70% of patients who respond, the clinically meaningful difference in ADL, etc., compared to placebo, etc., difference from placebo, etc. So I think that's an issue. And again, as Henry said, forget about the traditional drugs. We have no way of predicting which patient's going to respond to one or the other of the C5 inhibitors or one of the other newer classes approved, the FcRn antagonists. So we really have no way. So we are still somewhat practicing in the dark, and the practice is defined mostly by patient convenience, as Sri said, and payer input. And that's really all we can do. When you look at the data, however, I mean, again, looking at the studies, and if you look at those Christmas tree plots, percentage of patients responding 2% or up 2-point ADL all the way up to 10, 11 points. And I think that's a really salient point, for me at least in clinical practice. I don't want a 2 or 3% improvement in ADL. It all depends on where they start from. Somebody who starts with an ADL of 6, a 3-point improvement may be reasonable, but it also depends. If that 3-point improvement does not get their eyes, as Pritikanta was saying, and there's someone who works on a computer, it's pretty useless. So, and what I want is that robust response. And at least, and I'd like my colleagues' interpretation of this, but at least in practice, what I see is that patients tend to be on one or the other extreme. They respond beautifully. We are talking 7, 8, 9 points. Their ADL drops. They're almost symptom-free. Or they're like, running around like a little bit of improvement here. Yeah, I improved this. I improved that. I'm not happy with that. I improved a little tiny bit here anymore. I want that robust response and to get them down. And so I don't wait very long. I will change because my goal is to get them there. And that's part of the treatment goal. So I think that's sort of where, and also, as Henry said, we have no idea what are the drivers of the response in those people who respond at that 7, 8, 9 ADL change, and what are the drivers of the placebo response in these trials. And that's where sort of we need more data on this patient population and also more biomarkers. But I think that's the way sort of I approach my thoughts about efficacy in practice. Because if you use one of these and they only get a little bit of response, if you use the other one, sometimes you can get them all the way down. So there is a variability between the drugs as well of the same class. So.
I think most of it has been covered, in terms of the topic. So it will be repetition. I will add the perspective. One, I think that kind of is very important. Again, repeated, like patient preference, what patient prefers in terms of the route of administration. Some patients are very comfortable doing self injections versus, some patients like kind of think about they have to miss their work or vacation or trips, even if it's like once every 2 months. So I think kind of patients, that makes a difference in terms of which medication to choose amongst the available 3 different C5 inhibitors, given like the efficacy standpoint, they're all comparable. And so is, as my understanding, from the infection risk. The other thing which I would say is, given like the nature mechanistically as a little bit, the peptide versus the monoclonal antibody, and now you have newer drugs which are FcRn inhibitors. My personal experience, I might be more intent towards using the subcutaneous molecule, which is not a antibody, which might not be interfered by the FcRn inhibition treatment if we have to do some switching in treatments. I think that kind of makes a difference now, which was not there before the FcRn drugs got approved, in terms of mechanistically or theoretically. The peptide molecule zilucoplan may not be altered by use of FcRn inhibitors compared to the other monoclonal antibodies. And then the other thing I do want to mention, in the recent years, the decision about choosing C5 inhibitors as a first line often gets interfered about the vaccination schedule, which has been a newer in the recent years of completing up to 6 months of vaccination schedule, compared to previously it was only up to 2 months. So that kind of often makes a difference in terms of when you discuss with patients the risk of meningitis. Of course, there is a alternative path of using antibiotics of prophylactic if patients are not completely vaccinated all the way to 6 months. But I think that kind of makes a difference in treatment decision, how you choose about starting. That's applicable for all the complement inhibitors, but as a choice of first-line treatment when you're seeing a newly diagnosed or relatively newly diagnosed myasthenia patients, that kind of also makes a difference when you are considering C5 inhibitors.
Yeah, no, I agree with my colleagues in that the decision between using any of the three established complement inhibitors is very much driven by the patient choice. There are people who just don't want to self-inject themselves, regardless how easy it looks, and prefer that every 8-week scheduling. I've had some people who don't make it out to 8 weeks sometimes, at least in the initial few infusions, and also have individuals who have responded to eculizumab and don't want to switch over no matter what. So I think that the point about the peptide is really an important one, and I think something that we're just going to start learning how to use. So a nice thing about zilucoplan is you stop it and your complement activity returns to normal quickly. So if you need that, somebody has a significant infection or there's a concern that they shouldn't be complement inhibited, then at least that's reversed very quickly. And then also that point about being able to couple zilucoplan with IVIG or FcRn inhibitor. I had a young lady who is terrible myasthenia for decades and has been through everything and is still compromised. But the only thing I could think of is adding zilucoplan to her IVIG therapy, and she's had a significant improvement with her ADL going from 12 down to 3, and is even considering employment again. We could never develop a clinical trial to assess that, but again, what all my colleagues have said is the need to tailor treatment to that individual in front of you is key, and making joint decisions with the patient on going forward with any of their treatments, quite frankly.
And then when it comes to medications, there was additional frustration because oftentimes she wasn't sure about how to take the medication, when she was supposed to take the medication. Even if it's a steroid taper, when you're taking this many pills on day 1 and this many on day 2 and whatever, and for how long is she supposed to take this or that, and they're trying all of the different things, that kind of thing, and how long is something supposed to take before you start to see an effect. And when you're first having symptoms for so long before you're even diagnosed properly, I just think all of that patient education is so important to make sure that the patient knows what to expect, they're reassured, and it's just so important to have really great communication with the patient.
We try to offer therapies that are relevant to a patient, that make a difference to their particular needs as much as possible. We certainly escalate it to complement therapy. We don't always start with complement therapy. At the first time we see a patient, unless they've already tried other agents for various reasons, including vaccination, cost of care, so on. Complement therapies, I think, have a significant role to play in AChR positive MG patients, especially those who have had inadequate control with other therapies. I think Dr. Paul previously mentioned sort of the potential option of adding complement therapies to FcRn therapies, and that's very intriguing and very refractory or difficult to control patients. In those sort of situations, obviously, only one complement therapy can be added to an FcRn therapy, zilucoplan. The other ones are monoclonal antibodies, so they're not really, we cannot add them to an FcRn inhibitor because of loss of efficacy. I think the second thing that Dr. Narayanaswami mentioned, and I think it's relevant, and this is something that I think all of us who see a lot of myasthenia in practice experience, is that even if patient has a dramatic improvement, and I usually in clinic waiting for the patient to tell me, I feel so much better, thank you. And then, but I hear sometimes that, oh, they're not as happy as I expected them to be. Part of the reason is that they are continue to be burdened by the ongoing need for the treatment. And so this goes back to sort of patient resetting and goal resetting, and something to be aware of. Even if you were able to offer a significant reduction in their symptom burden post-complement therapy initiation, there is still an opportunity to rethink the treatment burden that is part of complement therapy, and whether that can be improved in future with sort of newer therapies that are in the pipeline. I think there is value there. Thank you.
Yeah, I sort of echo all the comments. One of the things I would emphasize, however, is in the excitement of the depth of response that we get for some of our patients here, what we really do have to remember is that we are sort of targeting the sort of the end point of the whole immune cascade response. We're really not this whole talk of upstream and downstream therapies. And I think I take that seriously because I'm not an immunologist, but to me intuitively, and I may be wrong, to me intuitively, it bears that to mind that if there's a disease process that's happening, I want to get it at the disease process. This is not quite symptomatic, obviously, because it's attacking the final common pathway, if you will, but we haven't done anything to the disorder. In my practice, there are a handful, I can count them on the fingers of one hand, of patients who are on one of these therapies as monotherapies. Everybody else is on a traditional sort of disease-modifying therapy, if you will, so non-steroidal anti-inflammatory, a non-steroidal agent or immunosuppressive agent or corticosteroids. And I think Preeti's and Henry's point about the role of a non-MAB complement inhibitor also comes up with the approval of other upstream therapies like inebilizumab, so that's MAB. We've got this as a macrocyclic peptide, so probably easier to use together than use two MABs together. I don't know. But so that's one thing that I think we have to keep in mind with the conversation, that we do not know what's happening to their disease. There's some sort of talk about how you modify end plate damage. Sure you do, but the antibodies are still being produced. I'll stop there and let Henry have his day.
I don't know why I got pushed to speak now, except that Pushpa always pushes me. So going back to the mechanism of action, I think that's addressed that in two levels, right? So we have the C5 inhibition, but there's two other effector mechanisms of these antibodies, right? So that probably explains why some patients don't respond, and specifically, whether the antibody is blocking the receptor channel function or it's cross-linking receptors and taking them off the surface of the postsynaptic membrane. So I think those are explanations why some patients don't respond. But I think it's also important to note that the autoimmune process is not static. So over time, it evolves. And I've had a few patients who have lost their responsiveness to complement inhibition. And so despite some like my folks doing great, I'm always in the back of my mind thinking that they're going to fail, and then going to Pushpa's point and everybody's point that we need to look at mechanisms of action and actually eliminate the B cells that are producing these autoantibodies. And even with the new B cell depleting agents, there's still a group that's not responsive. They're surprisingly poorly responsive. So we have a long way to go to integrate those treatments, the newer treatments, into how we practice. So as we've all spoken, quite frankly, the clinical trials are not adequate to educate us on how to really personalize treatments in our common practice. So
I'll just add to what Dr. Kaminski mentioned, in terms of the clinical trial, just coming out of being passionate about MG, it's kind of disheartening, every time you see patients, they're on high dose and higher dose of steroids and going through these side effects in terms of clinical trial, some sort of future directions where that should be considered or as one of the outcome measure in terms of the absolute dose or something. I think there is a difference between, that's how I think, I don't know if others will agree, like going down from say 30 to 20 milligram of prednisone versus going down from 20 to less than 10 milligram of prednisone. In clinical real world life, that makes a huge difference for patients, but we don't captured that, or we don't define that as an endpoint for a clinical trial. So that's a huge thing. If you look at all the studies, patient experience, more than 50%, they talk about how detrimental the steroid-related side effects, and people don't want to. And all of us mentioned like how people compromise and get used to this residual weakness they are living with in MG. That's one. And again, I think the other point, I mean, I'm sure people have experienced that. It's just, again, from the standpoint of being passionate, like MG is a fluctuating disease. And I feel like again, clinical trial versus real world, like there's a huge mismatch, and find other ways in terms of defining outcome measures, like how this maybe 30%, but this fluctuating or with so-called refractory, how do you define their like treatment goals and outcomes to say this medication is working or not?
Maybe I could add to that, because I agree 100% that, and I hear your passion, and I'm very passionate about this as well. I mean, I think there are new clinical trial designs, new outcome measures that we have to develop for myasthenia. And I would say even ones that are specific to that patient, right? I mean, that would be hard to do, but I think everybody appreciates that MG-ADL is completely inadequate. We're stuck with it now, but I think there's ways to really individualize outcome measures for each specific patient, and absolutely bringing the patient down to a dose of 5 milligrams of prednisone per day, which is safe, but also the point of coming down from 20 to 10, if that's the best you can do, is also very meaningful to that patient. And just to say one more thing, I was at a conference talking to really wonderful patient, and he gave me a different impression of, to me, going from an ADL of 6 to 3 made a huge difference in my life. So yes, we say that's a clinically significant difference. Often in a trial, looking at just aggregate numbers, I would say, man, that's not the greatest agent. But, for that individual human being, it made a huge difference in their functional level. So.
Can I just add, just to emphasize the field, I think maybe this is what Dr. Kaminski and Dr. Paul was trying to also say, is that there are obviously limitations to MG-ADL, the way it's used in clinical trial and clinical practice. In spite of dramatic increase in therapeutic options, the goalposts of what we think is optimal are considered more than acceptable in the clinical trials has not changed. We still use the same ADL metric and same bar to say a drug is effective. I was personally hopeful as we get more and more therapy, what we expect from a clinical trial situation, as well as in clinical practice, is higher than the earlier agents with the earlier bars. Because one of the challenges that we face as sort of practicing physicians is that, yes, the drug might be approved based on an ADL change, but when we go back to patient, we don't ever say to a patient, well, your ADL improved, and then we are done. We're actually taking care of the whole of the patient. And so, as Dr. Paul mentioned, once ADL is better, we're also starting to look at, okay, can we get you off some of the drugs? And some of that practice has to be translated into clinical trial with a sort of another outcome measure with a higher bar, which encompasses both the concomitant immunotherapy or the side effects of that immunotherapy, and sort of holistically measure the improvement.
Thank you to our faculty, and many thanks to you, our listeners, for joining us. As a reminder, to view the full program from mechanism to management, novel C5 inhibitors, and generalized myasthenia gravis, please click the link in the show notes. And be sure to check back regularly for more episodes on important neuroscience topics.